Plant your foot. Good news. Guess what? We're talking knees. And here's Charles. So, Nick Bosa, ACL tear. Apparently was a clean tear. Really? What is a clean tear? So, we don't really use that word for an ACL. It's either proximal, it's either distal. It's partial. It isn't associated with an avulsion fragment. Is it associated with other injuries? And I think, honestly, that's what the chatter was about. Clean tear. They were saying it was just isolated to the ACL as opposed to any other ligament or meniscus or cartilage or bone or any other associated trauma or injury that could happen. And this was his repeat tear. He's already torn his ACL on both knees. Now he did it on his right when he was landing, pivoting, when he was landing, falling, or maybe he landed like this, then twisted, then pivoted, then went down. So many different mechanisms. So was it a non-contact or a contact? Take a look and decide for yourself because it's hard to tell. The only person that really knows is going to be Nick Bosa. And you know why? Because right when you tear it, you know. Now in a revision, like a repeat tear, he's had the tear before, so he doesn't have the same proprioceptive nerve kinematic feedback loop. Like when you first tear your ACL, oh, it's painful. You feel every single fiber ripping, and you know exactly when it happened. For me, soccer. Boom, land, and right as it's tearing, I was like, screaming and realizing that I didn't scream.
Okay, I was going to ask.
Yeah, I didn't scream. I was just like being emphatic, just trying to be dramatic about it, but I didn't scream. It was just like, okay, it's my ACL. I'm just going to walk off it. Yeah. Although I did walk off it, I actually had to drive a stick shift after the game home and uphill. This was San Francisco in these soccer fields, the polo fields, and I blew it out, had to sideline, and then I had to climb up a hill, get to my car, and it's a stick shift. And it's my left knee. So anyway, Nick Bosa. So he had an isolated ACL tear according to what we know. Don't use the word clean. Whoever used that word, just delete, okay? It was an isolated ACL tear, which is good. It's just the ACL. Now, what can happen with the ACL tear? I'm falling apart. Charles, you're not healing. So, ACL, that's torn. You can have it from the proximal, from the distal, mid-substance. It could be a partial anterior anteromedial bundle, posterolateral bundle. It could be a partial anteromedial, partial posterolateral, or a combination of multiple areas. Just remember, our terminology for anteromedial and posterolateral bundle comes from, you guessed it, biomechanic, artificially reconstructed mechanics and kinematics of the knee in dead tissue, cadaveric tissue, that recreates injuries artificially, synthetically in cadaveric synthetic tissues in order to create a tear in dead tissue that's not living without nerve or blood supply in order to give us a sense of what's happening. And when we did that, we see anteromedial and posterolateral bundles that are tight in certain positions, taut and loose in other positions. And so there's a lot we could really dive into in the ACL, and we will. Oh my God, we will. But the real world kinematic live data of an injury or the recovery when you're watching the ACL in vivo, that is what's going to transform this space so much. And we can't do that right now. It's coming, but we can't do that right now. However, isolated ACL tear, he's going to go a revision surgery. Now, hold on. I hear you in the back. You're saying, why does he need surgery? You're right. He doesn't need surgery. Could he live without an ACL? Sure. Could he play football without an ACL? Well, a quarterback's proven that. What's his name? John Elway. He's proven that you can actually play professional football without an ACL. Pretty impressive. But is he going to play without an ACL? Unlikely. So he's going to have a revision surgery. And this is a good opportunity to bring up the multiple different types of ways you can reconstruct the ACL. So typically, in all cases, currently with standard of care, you have to have some degree of a bone tunnel, which acts like a socket, almost a docking slot to put the ligament or bone ligament construct in the tibia and in the femur. And whether that bone socket or bone tunnel is full length, partial length, just not a large hole in the cortical side, smaller hole, all inside, fully open. There's so many ways to do the surgery. And then there's the ligament choice. Do you use a graft that's fully autograft, allograft, autograft, a combination, or do you actually augment that graft with something else? Commonly, there's a suture augmentation being used. And historically, there was the ligament augmentation device, the LAD, the Kennedy LAD. And unfortunately, that used a type of material, Gore-Tex, and that had severe problems. So there were problems with that. But the pendulum keeps swinging. Now we're doing a ligament augmentation device, but they're not calling it a ligament augmentation device. It's a ligament augmentation device. But the LAD, I believe, had a trademark, LAD, and it had a lot of negative repercussions long term, although I know people that still have an LAD and are still functioning and have good knees, but there was a decent percentage of failures and complications, so the LAD went out of favor. And now we're basically using a device that's augmenting the ligament. Yeah, I just said DAL, didn't I? Yeah, avoids trademark. But anyway, so, and then there's different techniques. Do we do just the anteromedial bundle if it's partial torn, or do we do just the posterolateral bundle? Or maybe we do the bone tunnels completely separate and do two separate ligament bands for the two supposed bands that we're aware of. Now, let's just say this is the meniscus. I'll give it back, Charles. Don't worry. I'm just taking out your whole meniscus. Let's just imagine this is your ACL, right? It's a three-dimensional construct, twisted. Now, if we were to open it up and rip it apart and you start saying, well, there's one band here, there's two bands here, they're tight in different locations, but isn't that what every type of rope does? Any rope in a different configuration will be tighter depending on how it's wound. It's still a three-dimensional construct, which means every single fiber is important. So you can't just make anteromedial bundle a certain tightness and posterolateral bundle a certain tightness and expect it to be 100% organically, natively constructed with all the kinematic strains and resistance associated with it. So, I know that was a mouthful. What am I talking about? Sometimes I just talk and then it's because it's all unscripted and it just goes. Yeah, that's why we switched to YouTube Shorts, right? Yeah, because if you're actually watching the full video, you're nuts. Why would you watch me for that long? Just watch the shorts. Seriously. We've already talked about rehab. We've seen that before. We've talked about recovery. We've talked about proprioception. What do you want to know? Write it down in the comments. Or just, if you haven't even watched this full video, don't. Just watch the short, dude.
So there's no more complications with it being a second ACL tear?
Oh, yeah. So So the question from the peanut gallery behind the camera, which is a very good question, is are there more complications associated with a revision ACL? Well, let's start from the beginning. Okay, when you first tear your ACL, that's your boom. We talked about that click. Oh, it's a good sound effect, eh? I'm getting pretty good at this. That wasn't so good. So you get the chondral impact. The chondral impact injury that happens right away is the biggest, most important, and that has long-term consequences. The other aspect is the meniscus tear and any other associated ligament injuries and the loss of that proprioceptive feedback because of the neurovascular attachments that are related and around the ACL, partially and fully, depending on what part of the ACL you're talking about. Now, is it going to be worse with a revision? Well, I would say yes and no. And, engineers love that term. It's like, can we fix this? Yes and no. Is this going to be 100%? Yes and no. So
when you do that, you have to go 6'7".
6'7"?
Yeah.
Why 6'7"?
You haven't heard that?
No.
Oh.
What's 6'7"?
Kids. The kids. 6'7". It's some dumb thing from TikTok that is
Viral?
It's insanely viral.
Okay, for you TikTok users,
6'7".
yes and no?
6'7"?
Or 6 and 7. Whatever that means. Whew. Ah, my palm is itching. I think we're going to get a bunch of subscribers coming up. So when we're talking about the repercussions, you should always go back to the original injury. Now, we're talking over 90% of ACL tears will develop, or in fact, you could argue it's 100%, but 90% within 20 years and 100% of ACL tears will develop post-injury, post-traumatic, degenerative, and post-traumatic injury-related osteoarthritis, or chondral injury, or cartilage degeneration, or chondromalacia. Pick a term. You're going to get wear and tear of your cartilage, which will affect the bone, and it'll affect and develop arthritis. So all ACL tears will develop that at some point, and 6 or 7, the number actually varies depending on the publication you read and the long-term outcomes. Now, the most quoted long-term outcome is 90% in 20 years or 75% in 20 years. See? 6 and 7. I don't get it. What the heck is 6 and 7?
Say that to your daughter when she comes home.
She'll know exactly what it is. Okay. All right. So when we're talking about 6 and 7, and when we're talking about is it more complicated, one would actually argue that doing a revision is actually easier. You know, if it's an isolated ACL tear, you've been in there before, and even if you haven't, here's the thing. If nothing else is torn, you don't have that big bloody mess you often see with a fresh ACL tear. Because a fresh ACL tear, you've got fibers and all the blood supply. That was pretty good, eh? Just throw some sound effects, a little color, a little.
That's the screenshot.
That's a screenshot. So when you have that fresh ACL tear, whether it's mid-substance or from the proximal attachment or the distal portion, you go in there and it's like spaghetti fibers oftentimes. Or if it's even a few weeks old, sometimes they get tethered and it fools some people. Mostly, you know, the early residents or med students will not necessarily appreciate it, but any seasoned surgeon will know that whether an ACL has scarred down in a certain way and it's not actually attached anymore. But if we're assuming it's relatively fresh and they've got their motion back and you go in and it's still a bloody mess, shall we throw a British accent in there?
Yeah, absolutely.
Bloody mess. That was a terrible British accent. Bloody mess.
Better.
Better? Okay. All right. Let's just get a Brit on. Come on, Brits. Let's go. Let's have some soccer injuries. Well, let's not have some soccer injuries, but if you got a soccer injury, we'll talk about it. So, going back to the complications, or is it riskier, or is it harder, or is it more problematic to have a revision. The part that's more problematic is the fact that you've torn it again, and did you have another chondral injury? So if you snapped and hit your condyles again and had another cartilage bruise or a chondral swelling, or essentially bone bruise as we used to call it, because you would have edema on the MRI and it would show up and it's a bright signal because there's blood in the marrow. And I'm sure if you've had an ACL tear, your doc has explained that to you. And if you have that again, then that's another chondral injury. So most of the challenges associated with it become long-term. Now, is it going to affect his short-term contract? I don't know. I don't have a crystal ball, so I can say 6 or 7. However, if we talk about the actual surgery, it's actually quicker, in my opinion. A revision surgery, let's assume it's isolated, nothing else is intact. You might have some scar tissue, you might have had a little bit of a cleanup to do, but you're just going in there for a literal surgical strike. You're gonna rip out the old one. Now, the part that gets problematic is if he had suture augmentation or some type of a ligament augmentation device before. Now, we don't know that. So, because when you try and debride all that junk out, you can leave little polyester, let's just say polyester to make it easy, but there's so many different types of, suture material. But whatever that material is can stick around. And so it was the problem with the Gore-Tex fiber, and certain carbon implants that were used in the past are graphite implants, and that can become a problem, and I still sort of predict that may be a problem in the future, but 6 or 7, no crystal ball here. Why do I keep saying that? Because it's stupid.
It's algorithm.
It's just algorithm based, right?
Completely different demographic.
You would totally different graphic. So we're going like, and we're going. And then you would just do the video. Keep talking. Yeah.
One thing.
Are we still rolling?
Is there any so part of the recovery is like the mental recovery and the trust of the ligament. And again, having the ACL tear a second time would I was getting to,
yeah.
Would he trust it faster?
Yeah, so that's what I was going to get to. So now we're talking about the second time. So the surgical part, like I said, becomes pretty straightforward in a sense, because then you decide. You have the conversation, autograft, allograft. And then you have the conversation, well, do you want us to take, if he had hamstring before, do you take the bone, tendon, bone? If he had bone, tendon, bone, do you go for the quadriceps? And if you had quadriceps before, where else can you go? Well, once you have it and you've gotten one area of your knee taken, then going to allograft makes sense. But he's young athlete, so autograft has a higher, according to all the statistics, 6 or 7, the risk of a re-rupture is lower with autograft. Now, this is a revision situation. So now he's had an ACL tear before. He's having it again. He's having surgery. So he knows exactly what to do. He's prepared for it. Mentally, he knows, I'm going to have surgery. I'm going to have a brace. It's going to be sore. I'm going to be walking. Then I'll be running after jogging and get my balance, get my proprioception. And it took me 2 years to get solid, but I know I can play at this time because that's what it was like before. So from the rehab standpoint, I do believe a revision ACL comes back sooner. Also because if you're having autograft, if you're having allograft, you're not dealing with the harvest site. So there's donor site, harvest site, donor site morbidity. What that means is you have pain, injury, swelling at the site you took the graft. So if you took it from your hamstrings or you took it from your quads, it all depends in terms of the soreness related to that. So there's a lot, and especially if you have bone, tendon, bone, then you have soreness there. There's an anterior knee related pain and symptoms, and in female athletes, the risk of a patellar fracture, chondromalacia patella, are higher. So you tend not necessarily to do that in females, but again, it can vary between surgeons, patients, and the conversation. The conversation between physician and patient in terms of deciding what you do is the most important, and understanding the repercussions and the rehab process involved, as well as the risks and benefits and complications associated with it. So, and that being said, of course, this is all education. This is not medical advice. And so please take it as education in general. And for a frame of reference, we're talking about Nick Bosa.